back to our urinary system pathology lecture series. Today's lecture will cover renal anomalies. The renal anomalies that we'll be discussing today include renal agenesis, renal hypoplasia, bifid renal pelvis, renal ectopia, crossed renal ectopia, cake kidneys, and horseshoe kidneys. When we see renal anomalies, these are more likely to affect how the kidney functions. Either the kidney isn't there, it's not functioning appropriately, it looks very different, there's more susceptibility to different pathologies that can be associated with these anomalies. So again, we want to make sure that we are documenting any anomalies that we see to make sure that we show the radiologist that not only did we see them, but to show the radiologist if anything is occurring concurrently with that anomaly in place. Our first renal anomaly then is renal agenesis. Again, breaking down the words is going to be very helpful for you to understand what is happening with them. So renal refers to the kidney, agenesis means abnormal generation or abnormal development. And so in this case, renal agenesis means it didn't develop. So renal agenesis can cause one or both kidneys to develop. It is thought to be due to some sort of vascular accident within the uterus. So maybe there was a clot, maybe something happened, somehow the blood flow got cut off to one of the kidneys, and therefore when our organs don't get blood, then they stop growing, and in that case of the in utero, it just kind of disappears. We won't ever see it. Maybe a very small remnant of something somewhere, but nothing that we'd be able to see. If it happens to both kidneys, it is incompatible with life and therefore will result in a uterine demise. Typically what happens is the kidneys are responsible for making that amniotic fluid. The fetus can no longer make amniotic fluid. If there's not enough amniotic fluid, the lungs cannot expand and develop appropriately, and that typically ends then in a demise. There are a couple things that we will want to look for with renal agenesis. If the patient knows that they don't have that other kidney, they probably have had previous imaging, maybe they've had a CT, maybe they've had another ultrasound. So always make sure that you're looking at previous ultrasounds and imaging to get that history on your patient. When we actually are scanning the patient, then we'll get to the renal fossa, either left or right, and it'll be empty. And so that's going to be our big first clue that something isn't right. There isn't a kidney in where we expect it to be. Now, just because the kidney isn't there, we'll learn a little bit that kidneys can migrate to other places. So we do want to make sure that we're checking other areas that kidneys like to hide. But if we check all those areas and can't find it, then most likely this will be chalked up to renal agenesis. The other thing that we'll notice, if there is only one kidney, typically the other kidney becomes very large. And that's because it's doing the work of two kidneys. So we call that compensatory hypertrophic kidney. The other thing that you might see, and this is probably going to be a little bit more apparent on our pediatric population, is called the lying down adrenal sign. Normally our adrenals are kind of a little bit more triangular shaped, but they are kind of folded in on one another. When the kidney is gone, but the adrenal gland is still formed, it kind of lengthens out and lies down. This is an image that I like to take when I am scanning babies. I usually take a cross-sectional view of the baby, so I'll have them in cross-section. This is the spine. Then I like to show both of those kidneys on either side of the spine. But then I also like to take this picture, and this is more of a coronal image of the fetus, and then I put color on, and we can see the aorta here. And the aorta is coming down and breaking off into each of the iliac arteries here. And what we don't see are renal arteries coming off on either side. Typically those renal arteries come off and then you'll have a kidney here and here. So this helps to prove if you don't see the kidneys in transverse, this can help to prove that you're not seeing them in coronal and that there is no blood supply to the area that we expect the kidneys to be in. The only downfall of this one is that the adrenal glands also need blood flow. And so sometimes the renal artery does still develop and then travels to the adrenal gland versus going to an actual kidney. So it is important that you are looking in two planes, trying to identify if those kidneys are present or not. The other thing, if the infant has or fetus has developed renal agenesis, then there will not be any fluid. So you can kind of see here, there's just body here. There's no fluid in between the uterine wall and the fetal body. So there's oligohydramnios, so low fluid or no fluid. and then eventually this will result in a fetal demise. Now the next renal anomaly is called renal hypoplasia. And renal hypoplasia, hypo means low, plasia means growth again, so low growth. This means small kidneys. True hypoplasia is considered when we only have 5 calyces to a kidney. Most of our kidneys have somewhere between 7 and 13 calyces. So true hypoplasia is when there is 5 calyces or less. We do not want to confuse this with what is called renal atrophy. Renal atrophy is typically due to some sort of disease, be it renal artery stenosis or some cystic diseases can cause the kidneys to become small. That is not the same as renal hypoplasia. Renal hypoplastic kidneys still function as they normally do, and they should look exactly like a normal kidney as well. They're just on the smaller side. When you are measuring the kidneys on ultrasound, we always want to make sure that we are kind of remembering what that right kidney measured. So when we measure that left kidney, we can kind of do the math in our head. Does this make sense for what I got? In the normal adult who does not have renal hypoplasia or renal atrophy, we expect those kidneys to be within about 2 centimeters of one another. So if I get a 9 centimeter kidney on the right and I get a 12 centimeter kidney on the left, I either measured incorrectly on the right or something's going on. So I'm going to go back, I'm going to measure those kidneys again on the right, make sure, try new windows, try rolling the patient, have them prone, make sure that I get an accurate measurement, and if I get persistent low numbers or a wide difference, then that is going to be cause for further follow-up. Maybe they need some more urine lab work, blood lab work, or maybe they will be diagnosed with this renal hypoplasia. So with adults, it is typically a difference of more than 2 centimeters. With children, we say more than 1 centimeter is a little bit more concerning. If there is a difference, again, this does not indicate renal hypoplasia on its own, but it does indicate that there is a size difference that needs to be followed. The next renal anomaly is the bifid renal pelvis, and this is one of the most common anomalies that you will see. With the bifid renal pelvis, the kidney has 2 collecting systems, and there are actually 2 versions of the bifid renal pelvis. There's complete and incomplete. The complete bifid system is going to have 2 renal pelvises, 2 ureters, and both of those ureters are going to insert into the bladder. The incomplete version, which is more common, is going to have 2 pelvises, 2 ureters, and then those ureters are going to join together at some point before their one insertion into the bladder. And we talked about earlier in the renal variant lecture that these patients tend to have a column of Burton, and that is true. So and you'll see it on the ultrasound pictures here in a second. But we have the kidney, there's typically an upper pole and lower pole, and you're going to have this column that kind of splits in between the 2, and you'll be able to see that very well on ultrasound. That's actually kind of a hallmark sign on ultrasound to indicate that there is a bifid system going on. So then this one's going to have its own collecting system and a ureter. This one will have a collecting system and a ureter that'll either join or they'll both head down to the bladder and insert. There are some considerations as far as pathology goes when we see that bifid renal pelvis. The upper pole is more likely to have complications, and usually it's going to be hydronephrosis. So we'll see a little bit of fluid up on the upper pole. The lower pole, while not immune to getting hydronephrosis, most likely will not have it. And the reason the upper pole is more susceptible is due to how that ureter inserts into either the other ureter or how it inserts into the bladder. That upper pole ureter tends to insert abnormally into the bladder if it makes it all the way down. Sometimes it inserts into the urethra. Sometimes it can insert into the vagina. So it's got a lot of issues of where it's heading. So we do quite often see pathology with that upper pole. So here are our ultrasound images. On the left picture here we have a bifid kidney, and as I had mentioned before, we can see that pertinent column of Burton that kind of splits in between both of the kidneys. And then this is our upper pole here and our lower pole down here. The picture on the right, again, we have that pertinent column burden, our lower pole, and now on our upper pole here, we're seeing that fluid within the renal pelvis, exhibiting that hydronephrosis that is quite common on the upper pole. Now, the only way that we can determine if this is a true complete or incomplete is to watch the ureteral jets. If we see two jets coming from the same side, then it is pretty safe to assume that the patient does indeed have a complete biped renal system. Our next renal anomaly is renal ectopia, and this is also known as an ectopic kidney, and there are actually quite a few variations, and we'll talk about a few of them. In general, though, renal ectopia means that a kidney has not gone to the position that we expect it to go to. When the fetus is developing, the kidneys start down in the true pelvis, and then their job is to ascend into their renal fossae that we typically see them in by the time they are born. Sometimes, though, they get stuck down there. Sometimes they migrate somewhere else. Sometimes they cross to the other side of the body. There is just some variation in how those kidneys are going to present. So the main location that we see renal ectopia is going to be as a pelvic kidney. Remember that they're supposed to start down in the pelvis and then they grow and ascend into the abdomen. So sometimes they get stuck down there, and when they do, they get their blood flow from the internal iliac artery and drain into the internal iliac vein. The ureter is also very short as it's very near the bladder, and so kidneys like this tend to have a few more issues. The other place that kidneys can go, which is very, very rare, is called a thoracic kidney. And that is where the kidneys somehow sneak around the diaphragm and actually get up into the thorax. And so there are CTs out there, kind of interesting, but it'll be a CT and there's a kidney hanging out right by the heart. So that's something that ultrasound isn't very good at diagnosing because we can't really see through the lung tissue. But so on our case of things, we see an empty renal fossa, we're going to go look in the pelvis first. Not there, we might start to suspect agenesis versus a thorax kidney. As I had mentioned before, ectopic kidneys are more likely to have complications. They're more likely to develop stones, UPJ obstructions, which are obstructions that are up at the pelvis of the kidney, or they might undergo some reflux. Reflux means urine traveling in the wrong direction, and that makes sense for that pelvic kidney. It has such a short ureter that it would be very easy for urine to reflux back into the kidney. Here's our ultrasound example of the renal ectopia. This is a pelvic kidney. You can see the bladder is just anterior to it. And so we will find the kidney just really in an abnormal position. That's where that renal ectopia comes from. Typically, these kidneys are also going to be malrotated. Remember, we kind of have those medial portions of the kidney facing into the body. With renal ectopia, they're going to rotate. And in the pelvis, we typically see them kind of facing upward. Again, remember that these are more susceptible to developing stones or obstructions, so we want to make sure that we're looking for fluid as well. Now, a variant of renal ectopia is crossed renal ectopia, and this specifically refers to one kidney heading over to the other side of the body. Typically, it's going to be the left kidney that heads to the right side of the body. And once it does that, there's a couple ways that can present as well. We can have crossed fused, where the kidneys are kind of stacked on top of one another, or we can have crossed non-fused, where the kidneys are independent of one another, just on the same side of the body. The thing that's interesting about crossed renal ectopia is that both ureters are still going to travel and insert into their expected spots. So say the left kidney does travel all the way over to the left side or to the right side, that ureter is long enough that it's going to snake through and travel and then insert on the left portion of the bladder. Here's an example then of a crossed renal ectopia. This is a fused example. So with the fused, you're going to see a really, really big kidney, basically, and it's going to look like two kidneys stacked on top of one another. So here is, it's kind of hard to tell, here is one kidney, and this is the second kidney here. And we can tell that they're connected right here in the middle. So these are fused renal ectopia variant. If it was unfused, we would just see two relatively normal looking kidneys hanging out on the same side of the body. Now our next kidney that we'll talk about is called the cake kidney. This is another renal variant, but the cake kidney causes both kidneys to start to migrate medial. So they both head in towards the center, and then they fuse to one another in that medial pole. So if this is upper pole, lower pole, we're looking at this medial portion that kind of globs together. And they're going to have normal collecting systems and ureter insert, just like the other one. But these ones are more likely to develop stones and pyochaliatasis. That's going to be dilation of the collecting system, so fluid basically within that collection system. On ultrasound then, they just kind of look like a big circle of kidney. They're still going to have a lot of the same features that we see on kidneys. They're going to have cortex, pyramids, a sinus, but it's just going to be one big circle, and we can see that here in this picture. The CT then shows us an example of the cake kidney having those medial poles fused together here, and then having the rest of the kidneys off to the side. Again, when we are scanning, quite often we'll look in the renal fossa, they're not there. If you start looking and you start to find kidneys a little bit more medial than you expect, then we're going to start to think cake kidney, maybe horseshoe kidney. We're going to look for anomalies. All right, our last renal anomaly that we will cover in this lecture is the horseshoe kidney then. So horseshoe kidney gets the name because they are connected on the lower pole and kind of make a U shape like a horseshoe. So this is another renal ectopia variant. And again, those kidneys are going to start to migrate a little bit more medial into the body. What they are going to do then is kind of build this tissue bridge, which is called an isthmus. And that bridge of renal cortex is going to sit anterior to the aorta and the IVC. So this is where it's very, very important that we are making sure that we are scanning all the way through our organs, both in transverse and in sagittal plane. In the transverse kidney, if this person was to have horseshoe kidney, we would follow that down in transverse. And if we kept following, making sure that we were not off angle through that transverse lower pole, we'd find that we would swing around and end up connecting back over to the other kidney. So again, you're looking in the renal fossa, you don't see kidneys there. If you're starting to move more medial and find those kidneys, start to think horseshoe kidney, possibly cake kidney. Horseshoe kidneys are a little bit more common. I've seen these probably 2 or 3 times over the last few years. Again, these kidneys are a little bit more likely to develop stones and that pyochaliatasis. Here are our images then of the horseshoe kidney. We've got the right kidney here, left kidney here, and then we have the isthmus connecting through. So those kidneys are connected by that lower pole. We can see right underneath it then that we have the aorta and then the spine below it here. Over on the other picture on the right side here, again, we have the right kidney and the left kidney, that bridge of renal cortex that comes across, and then we can see the aorta and the IVC underneath it. So remember that that isthmus should travel anterior to both the aorta and the IVC. So if you're kind of coming down, maybe you haven't even gotten to the kidneys yet on your ultrasound scan, maybe you're doing abdomen complete and you're coming down from the aorta, and then all of a sudden you get this kind of dark bridge of tissue, that would be a really key sign to identifying that horseshoe kidney. All right, that brings us to the end of the renal anomaly lecture. The next lecture will be evaluating a renal mass.